I mean, think about it. Millions of people literally woke up this morning, sat on the edge of their beds, and just did, well, a quick mental scan of their bodies, right?
Yeah, that morning inventory we all do.
Exactly. You check for aches, you check, your energy levels, and specifically for a lot of people, they check to see if they have a headache.
Right, which is where the danger really starts.
Based entirely on the outcome of that, momentary somatic assessment, a massive percentage of those people decided to skip their daily blood pressure medication today.
Which is terrifying when you actually unpack the physiology behind it.
It really is. I mean, they're operating under this assumption that a lack of physical head pain somehow equates to a normal cardiovascular system.
Like a clean bill of health just because nothing hurts.
Yeah, exactly. They are steering their entire health trajectory by staring at a diagnostic dashboard that simply doesn't even exist.
It's completely fabricated.
Right. So today we are taking a deep dive into a really fascinating, highly detailed exploration. This originates from the editorial and medical research team at iMedix.
The independent medical information platform, right?
Yep, that's the one. And the exploration they put together is titled The Silent Link, Blood Pressure and the Headache Myth.
It's such a crucial topic.
It is. So our mission for you today, as you're listening, is to really tear down this incredibly persistent medical fallacy. We're going to examine the behavioral psychology that, traps patients in these dangerous, symptom-driven dosing cycles.
And we also have to understand that critical gap between regulatory drug data and actual useful patient education.
Right, because that gap is huge. But I guess to start, why is this conversation even necessary? Why is this myth so stubborn?
Well, the necessity of this conversation really stems from, it's a fundamental mismatch between our human evolution and modern chronic disease.
Wait, evolution, like how we're wired.
Exactly. When we analyze the materials provided by iMedix, the core of their editorial blueprint really focuses on navigating the muddy waters of diagnostic interpretation.
Okay, so how we interpret our own symptoms.
Right, because if you look at human history, our survival basically depended on an immediate, recognizable correlation between tissue damage and sensory feedback.
So if I touch a hot stove, it hurts immediately.
Precisely. Nociception, which is the nervous system's response to harmful stimuli, it's an evolutionary alarm bell.
It tells you to stop doing the thing that's hurting you.
Yeah, or it tells you something is wrong internally, like you encounter a pathogen, you run a fever,
Right.
you fracture a bone, the localized pain prevents you from, bearing weight on it. The biological cause and the somatic effect are tightly coupled.
They go hand in hand.
Always. But chronic hypertension completely bypasses this localized alarm system. It is a systemic, gradual elevation in vascular pressure that offers absolutely zero immediate sensory feedback.
Wow. Zero feedback. And I imagine that creates a massive cognitive vacuum for the patient, right?
Oh, absolutely.
Because the human brain, it just abhors a vacuum, especially when it comes to internal physiological states.
We want to know what's going on inside us.
Right. So if a physician tells a patient, hey, you have a dangerous amount of hydrostatic pressure building up inside your arterial network.
Which is an abstract, kind of terrifying concept.
Yeah, totally abstract. The patient's brain immediately attempts to map that systemic threat onto a known, localized sensation.
It needs a physical anchor.
Exactly. So
Right.
the assumption that increased pressure inside the body must result in, pressure inside the head, a headache,
Yeah.
it feels completely intuitive.
It makes logical sense to a layperson.
It satisfies that psychological need for cause and effect. It's like treating your body like a car dashboard, right?
Right.
We expect a check engine, light like a headache, to pop up when the pressure's too high.
Right, but what if the car doesn't even have that light installed? And that's the danger. It satisfies the psychological need, sure, but it fundamentally misunderstands the biomechanics of the vascular system.
So what is actually happening? If there's no check engine light, what's going on under the hood?
Well, to understand why the body remains silent, we really need to look at the cellular level.
Okay, let's zoom in.
So the endothelial cells, these are the ones lining your blood vessels, they are equipped with mechanosensitive ion channels.
Mechanosensitive.
Yeah.
So they physically feel the pressure.
Exactly. They are basically microscopic pressure sensors. And when blood pressure rises gradually over months or years, these channels detect that increased shear stress from the blood flow.
But they don't send a pain signal.
No, that's the thing. Instead of transmitting a pain signal through the peripheral nervous system, they trigger a cascade of structural adaptations.
Wait, adaptations like the vessels change shape.
Yes, exactly. The smooth muscle cells in the tunica media, which is the middle layer of the blood vessel, they begin to hypertrophy.
Hypertrophy, like how muscles grow when you work out.
That's a perfect analogy. They actually thicken and stiffen to withstand that constant mechanical load.
Wow. So the infrastructure is literally remodeling itself to survive the immediate mechanical stress rather than sending a distress signal to the brain.
Precisely. The body prioritizes structural integrity over alarming you. And concurrently, you have the baroreceptors getting involved.
The baroreceptors, right. Those are the ones in the neck, right?
Yep, the specialized mechanoreceptors located in the carotid sinus and the aortic arch. They undergo a phenomenon known as resetting.
Resetting. What does that mean in this context?
Well, under normal conditions, these receptors fire action potentials when blood pressure stretches the vessel wall.
Right, so they sense the stretch and fire off a signal.
Yeah, and that signals the autonomic nervous system to lower the heart rate and dilate the vessels, keep things balanced.
Okay, so that's the normal feedback loop.
Exactly. However, when exposed to sustained chronic hypertension, the actual molecular conformation of these receptors alters.
They physically change.
They do. Their threshold for firing increases, so they effectively accept the elevated pressure as the new physiological baseline.
Oh, wow. So they just calibrate to the pathology.
They absolutely do. It becomes the new normal for them. And because the brain parenchyma itself, the actual brain tissue, lacks nociceptors, the central nervous system is entirely insulated from the sensation of this elevated pressure.
The brain literally cannot feel it.
No. Meanwhile, the organs like the nephrons in the kidneys, the delicate vasculature of the retina, the myocardium in the heart, they are sustaining progressive microvascular damage from the sheer force of the blood flow.
But the central nervous system registers absolute silence.
Complete silence. So your reliance on a headache as an indicator of hypertension is not just slightly inaccurate. It is a profound misunderstanding of vascular neurology.
Okay, I have to play devil's advocate here for a second. Let me introduce some friction.
Please do.
Because clinical literature does actually acknowledge a relationship between blood pressure and head pain in some specific scenarios.
Right, in emergency settings.
Yeah, if we look at emergency medicine, patients presenting with a hypertensive crisis frequently report severe headaches.
They do, yes.
So we can't tell you, the listener, that the link is entirely fabricated if there are documented instances where the two correlate, right?
That is a very fair point, and that distinction is paramount. It requires us to separate chronic pathology from acute vascular failure.
Okay, so everyday high blood pressure versus an emergency.
Exactly. A hypertensive urgency or emergency, which is typically defined by a systolic pressure exceeding 180, or a diastolic exceeding 120, that operates on a completely different biomechanical paradigm than chronic hypertension.
So what's the key difference? Why does one hurt and the other doesn't?
The key variable is the velocity of the pressure change.
How fast it happens.
Right. When pressure spikes violently and abruptly, the autoregulatory mechanisms of the cerebral vasculature simply fail.
Because the system doesn't have the time to initiate that muscle thickening or the baroreceptor resetting you just described.
Exactly. It gets caught completely off guard. Normally, cerebral autoregulation maintains a constant blood flow to the brain, despite fluctuations in systemic pressure, by constricting or dilating the cerebral arterioles.
So it normally protects the brain from pressure changes.
Yeah, but during a hypertensive crisis, the sheer mechanical force overwhelms that constriction.
It just blows right past it.
It does, and that sudden hyperperfusion damages the blood-brain barrier. The endothelial tight junctions actually begin to break down, allowing plasma and fluid to leak into the interstitial space of the brain.
Oh, wow. So fluid is actually leaking into the brain.
Yes, this is cerebral edema.
And the edema is what finally triggers the pain response, not the blood pressure itself.
Precisely.
Because the accumulation of fluid increases intracranial pressure, which stretches the meninges, the protective membrane surrounding the brain.
Right, and unlike the brain tissue itself, the meninges are densely innervated by the trigeminal nerve.
So they can feel pain.
Very acutely. You've isolated the exact mechanism there. The pain is a secondary cascade resulting from catastrophic structural failure. It's not a primary symptom of the pressure.
Wow. Okay, so that makes sense. But the danger of the headache myth is that it takes this extreme clinical exception, the hypertensive emergency, and just broadly applies it as the daily rule for routine chronic hypertension.
Right, and patients just assume that if they are not experiencing the secondary symptoms of a failing blood-brain barrier, Their resting blood pressure must be within a safe, normal range.
Which introduces a terrifying behavioral trap for people. And this moves us away from the pure biology and into the practical safety implications that the iMedix editorial team outlined.
Yeah, this is where the real-world danger comes in.
Because we are dealing with the application of the health belief model here.
Which is a huge factor in patient behavior.
Yeah, it suggests that a patient's adherence to a treatment protocol is heavily influenced by their perceived susceptibility to the illness and the perceived severity of the consequences.
Right, how much danger they think they're actually in.
Exactly. So if a patient believes hypertension manifests as a headache, their perceived susceptibility basically drops to 0 on any day they don't have head pain.
They wake up, they feel fine, they think they are fine.
And that cognitive framework leads directly to symptom-driven dosing.
Which is perhaps the absolute most dangerous behavioral outcome in cardiovascular medicine.
It's basically a roll of the dice every morning. Let's trace the actual pharmacological consequences of this behavior.
Okay, let's walk through it.
So a patient is prescribed a daily ACE inhibitor, or maybe an angiotensin II receptor blocker, to manage their hypertension.
Very common medications.
Right. They wake up, feel no headache, and skip the dose.
Because they think they don't need it today.
Exactly.
Yeah.
But they're not merely leaving their blood pressure unmanaged for that 24-hour period, right? They're inducing physiological chaos.
Complete chaos. Because the body relies on the pharmacokinetics of the drug to maintain vascular stability.
So they're used to having that drug in the system.
It is. When the drug is abruptly withdrawn, you don't just return to your baseline high blood pressure. You risk rebound hypertension.
Which is a huge spike, right?
A massive spike. The sudden absence of the medication can trigger an exaggerated sympathetic nervous system response.
So the body kind of panics.
Exactly. The renin-angiotensin-aldosterone system, which is what the medication was suppressing, it just goes into overdrive.
Okay, so all those systems just flood back in.
Right. Angiotensin II levels spike, causing profound vasoconstriction. The vessels clamp down hard.
Wow. So the patient, by basically using their lack of a headache as a diagnostic tool, has inadvertently subjected their vascular endothelium to extreme volatile fluctuations in sheer stress.
Yes. And these rapid variations in pressure are highly atherogenic.
Atherogenic, meaning they cause plaque.
Exactly. They promote the formation of arterial plaques far more aggressively than a stable, albeit elevated, pressure would have.
Oh my God. So the patient is actively accelerating their risk of a heart attack or an ischemic stroke, all while operating under this delusion that they are managing their health efficiently.
It's incredibly tragic. And what's particularly insidious about this cognitive bias is its demographic reach.
Yeah, let's talk about that, because there's this tendency in public health discourse to attribute poor medication adherence solely to, low health literacy or socioeconomic barriers.
Right. We tend to blame a lack of education.
But the somatic anchoring effect, this deep-seated belief that physical illness must produce physical pain, that's universal, isn't it?
The clinical data supports that assertion entirely. It affects everyone. Highly educated demographics, including healthcare professionals who understand the pathology intellectually, still fall victim to this heuristic in their personal lives.
Wait, really? Even doctors and nurses do this?
Yes. The cognitive dissonance is profound.
Mm-hmm.
A patient might understand on a rational level that hypertension is the silent killer.
Right. We've all heard that phrase.
But the evolutionary imperative to rely on sensory feedback completely overrides that rational understanding in the daily, mundane routine of taking a pill.
That is wild. They basically develop an illusory correlation.
Exactly. If they happen to have, say, a stress-induced tension headache on a day their blood pressure happens to be slightly elevated, their brain immediately locks onto that correlation.
And it just discards the thousands of days where the pressure was elevated without any pain at all.
Yep. Confirmation bias at its finest.
And this creates a chaotic feedback loop. I mean, headaches are ubiquitous. They're triggered by everything: dehydration, cervical spine tension, caffeine withdrawal, ocular strain from staring at a screen.
Literally just looking at your phone too long.
Exactly. So if a patient has anchored their cardiovascular management to this generic symptom, they end up dosing their antihypertensive medication in response to staring at a computer screen for too long.
They are applying a pharmacological intervention for a systemic vascular disease to treat a musculoskeletal or environmental issue.
Which is just crazy when you think about it. Which actually brings us to the crux of the iMedix mission here.
Right, the information gap.
Because the gap between prescribing a medication and ensuring safe patient behavior It clearly cannot be bridged by mere data distribution.
No, we have to examine the tools we currently use to inform patients.
Okay, so let's look at the standard process. When a prescription is filled at the pharmacy, the primary vector of information is the generic drug monograph, right? That dense, standardized printout they staple to the bag.
That long receipt-looking thing, exactly.
So, again, devil's advocate here.
Okay.
The monograph is a highly regulated, comprehensive document. It lists the molecular structure, the pharmacokinetics, the contraindications, and literally every adverse event recorded during clinical trials.
Everything is in there.
Right. So from a purely informational standpoint, it represents total transparency. Why is total transparency insufficient to protect a patient from the headache myth?
Because transparency without context creates cognitive overload, and cognitive overload breeds misinterpretation.
Okay, unpack that for me.
We must evaluate the epistemology of the drug monograph. What is its fundamental purpose?
To inform the patient, I would assume.
Actually, no. The monograph is fundamentally a medical legal document designed for regulatory compliance and liability shielding.
Oh. So it's to protect the drug company.
Basically, it is engineered to ensure the manufacturer has disclosed every conceivable statistical anomaly to protect against litigation. It is not engineered according to the principles of human learning or cognitive psychology.
So it's not made for humans to actually understand and use. Let's apply that directly to the cardiovascular pharmacology we've been discussing.
Okay, let's use a real example.
Imagine a patient who already implicitly believes the myth that high blood pressure causes headaches.
Which we know is very common.
Right. They go to the doctor, they're prescribed a calcium channel blocker like amlodipine, or maybe a vasodilator like a nitrate.
Standard prescriptions.
Right. They go to the pharmacy, unfold this massive, legally compliant monograph, and scan the common side effects section.
And what do they see?
Right there, mathematically validated by clinical trials, is the word headache.
The interaction between the patient's pre-existing schema and that single data point is disastrous.
It confirms their worst fear.
Exactly. The patient initiates the pharmacological therapy. A few days later, they experience a headache. Their internal heuristic tells them a headache equals dangerous blood pressure.
And the monograph confirmed the drug is associated with headaches.
So the patient, logically but incorrectly, deduces that the medication is exacerbating their condition.
They assume the drug is raising their blood pressure.
Right. So what do? They discontinue the therapy to protect themselves.
Wow. But the pharmacological reality is the exact inverse of what they think is happening.
It's the complete opposite.
The headache is the physiological manifestation of the drug successfully executing its mechanism of action.
We have to explain the mechanism of vasodilation to really understand why this happens.
Okay, let's break down vasodilation.
So medications like calcium channel blockers, they inhibit the influx of calcium ions into the vascular smooth muscle cells.
Okay, so it blocks calcium. What does that do?
It prevents contraction, causing the vessels to relax and widen.
They just open up.
Right. And nitrates achieve a similar result by donating nitric oxide, which stimulates the production of cyclic GMP, leading to that same smooth muscle relaxation.
Okay, so both drugs are basically forcing the pipes to widen.
Yes. This systemic vasodilation significantly decreases peripheral resistance, effectively lowering the blood pressure.
It's doing exactly what it's supposed to do.
Yes. However, this vasodilation is not restricted to the systemic circulation in the body.
It also affects the cranial vasculature,
And that is the critical mechanism.
the blood vessels inside the head.
Right. The blood vessels in the meninges dilate rapidly, and this sudden dilation can trigger the release of vasoactive neuropeptides, like calcitonin gene-related peptide, or CGRP.
Which promotes inflammation, right?
Yes, neurogenic inflammation, and it stimulates the trigeminal nerve fibers we talked about earlier.
And the resulting sensation of all that stretching and inflammation is a headache.
Exactly. But this headache does not indicate an increase in systemic blood pressure. It is the direct result of the pharmacological lowering of the pressure.
Oh, wow. So the symptom the patient interprets as clinical failure, that the drug isn't working, is actually the biological proof of clinical efficacy.
It's proof that it is working.
That is just wild. And this is the exact friction point where raw data fails and contextualized education basically becomes a matter of life and death.
Absolutely.
Because the monograph simply lists headache as a noun, completely devoid of its physiological verb.
It gives you the what, but not the why.
It provides the what, but deliberately omits the why and the how.
And this failure of the monograph really illustrates the indispensable role of independent medical information platforms like iMedix.
Because they have a totally different structural purpose.
Right. Their structural purpose is to act as a translational layer between that raw pharmacological data and actual patient comprehension.
So they take the legalese and turn it into human education.
Exactly. A platform designed for true patient education doesn't just list side effects as bullet points. It anticipates the cognitive biases and the pre-existing myths the patient brings to the table.
So an effective educational resource basically intercepts the myth before the patient can act on it and hurt themselves.
It gets ahead of the misunderstanding.
Instead of a scary bullet point, it provides a narrative. It explains the nitric oxide pathway or the calcium channel inhibition in accessible language.
It gives them the physiological verb, as you said.
Yeah, it explicitly states, like, hey, this medication lowers your blood pressure by relaxing the walls of your blood vessels. Because the vessels in your head are also relaxing and expanding, you may experience a headache during the initial phase of treatment.
This is a normal physiological adjustment to the medication, not a sign that your blood pressure is rising.
Exactly. Just
Yep.
having that context changes everything.
By providing the mechanism, the platform treats the patient as an active intellectual participant in their own care. It neutralizes the fear generated by that somatic sensation.
So the patient experiences the headache, they recognize it as the CGRP release, secondary to vasodilation that they just read about, and they continue taking their medication.
The contextualized information literally breaks the cycle of symptom-driven dosing.
It saves them from that rebound hypertension trap.
Eh,
But, relying on independent platforms introduces a whole other layer of complexity, doesn't it?
It does, from a regulatory standpoint.
Right, because we have the rigid, liability-driven world of regulatory agencies like the FDA or the EMA on one side, and then the localized, subjective, somatic experience of the patient on the other side.
And independent databases basically sit right in the middle.
Yeah. So how do these platforms navigate that regulatory context without violating the strict legal parameters of medical communication? They can't just say whatever they want.
No, they can't. It requires a profound understanding of medical linguistics.
Medical linguistics, how so?
Well, regulatory agencies operate on a lexicon of absolute precision, and they focus heavily on worst-case scenarios.
Covering their bases.
Right. When the FDA mandates a black box warning or specific phrasing in a drug label, they are primarily speaking to the prescriber and the legal system.
They aren't really talking to the patient at all.
No. They are establishing the absolute boundaries of safe pharmacological application. Independent platforms must respect to those boundaries while simultaneously translating that dense lexicon for the patient.
It's an epistemological balancing act.
Mhm.
You can't contradict the regulatory label, but you have to interpret it.
Exactly.
If a regulatory warning states that a drug causes cerebrovascular adverse events, the average patient reads that and imagines an immediate fatal stroke.
Of course they do. While the clinical reality might be that the drug causes a transient ischemic attack in, 0.01% of patients who already have pre-existing carotid artery stenosis.
Right. Context is everything.
The independent platform's job is to contextualize the absolute risk versus the relative risk. In the context of our headache myth, the regulatory label merely catalogs the symptom.
It just says headache.
The platform must weave that symptom into the broader medication safety discussion. It must explain that safety doesn't always mean the absence of symptoms.
Wow, that's a powerful point.
Sometimes safety is understanding what the symptom actually signifies.
And this just shifts the entire paradigm of how we define health literacy, doesn't it?
It really does. It elevates it.
Because health literacy is no longer just the ability to, read a prescription label or locate a generic monograph in the bag.
Anyone can read a list.
It is the ability to interrogate your own physiological assumptions. It requires you, the patient, to recognize that your intuition, this evolutionary hardware that associates pain with damage, is fundamentally unsuited for managing modern silent chronic diseases.
Right. The transition from being a passive recipient of medical data to an active participant requires recognizing the limitations of your own interoception.
Your ability to feel what's going on inside.
Exactly. You simply cannot feel your baroreceptors resetting.
No,
You cannot feel the hypertrophy of your tunica media.
It's invisible.
Therefore, you must outsource your diagnostic awareness to objective clinical tools like routine blood pressure screenings or home monitoring devices.
And you must outsource your pharmacological understanding to independent, contextualized, educational resources like iMedix.
You need a translator you can trust.
Exactly. So let's zoom out and synthesize the architecture of this deep dive.
Let's bring it all together.
We really initiated this exploration by targeting a deeply entrenched fallacy, right? The assumption that high blood pressure generates a reliable somatic alarm bell in the form of a headache.
The check engine light that isn't there.
Right. We dissected the evolutionary psychology that makes this myth so incredibly seductive, and we examined the cellular mechanics of vascular adaptation to explain why chronic hypertension is almost entirely asymptomatic.
And then we differentiated the silent progression of chronic disease from the catastrophic failure of a hypertensive emergency.
Which was a crucial distinction.
Yeah, clarifying that while extreme pressure spikes can cause cerebral edema and subsequent pain, applying that logic to your daily management is a critical error.
A dangerous error, because that error leads directly to the behavioral trap of symptom-driven dosing, where patients subject their cardiovascular systems to the violent mechanical stress of rebound hypertension simply because their head doesn't hurt that morning.
And we saw how generic drug monographs, which are constrained by medico-legal frameworks, actually exacerbate this danger.
By listing headache as a side effect without explaining the underlying mechanism of vasodilation.
Exactly. And ultimately, we established that raw medical data is functionally useless and, honestly, often dangerous without the translational context provided by independent medical platforms.
Because education is not merely the transfer of facts, is it?
Not at all. It is the deliberate dismantling of pre-existing cognitive biases and the building of a precise physiological understanding.
So, taking control of your cardiovascular health means accepting that the most dangerous forces operating inside your body are often completely silent.
You have to respect the silence.
It means resisting the urge to let your daily comfort dictate your medical decisions, and seeking out the resources that explain the profound, complex mechanisms working beneath the surface of your awareness.
Knowledge really is the only defense here.
It truly is. Which leaves us with a necessary, maybe slightly uncomfortable question for you to ponder today.
I love a good lingering question.
We have just spent this entire deep dive deconstructing the seemingly intuitive link between high blood pressure and headaches, revealing it to be a dangerous illusion born of evolutionary mismatch and misinterpreted pharmacology.
A total mirage.
So if a physical correlation that feels so incredibly obvious to millions of people is actually a systemic mirage, what other definitive, unquestioned biological signals in your daily life are simply well-disguised fictions, waiting for the right data to tear them apart?